Hi everyone, this is Mr. Neil Wrighteter, also known as the Wax Whisperer. Thank you for tuning into my latest video. So I have a patient who attended with a blocked right ear. It's been blocked for the last month or two. On first appearance, this blockage looks like earwax. However, it's not. It's actually dead keratin. And as we go through the procedure, you'll begin to see the landmarks and traits of dead skin in the ear. So dead skin in the ear, we call that keratin because as the skin dies, it becomes keratinous. There's a protein that is secreted within the skin cells called keratin. Keratin is the same protein that you find on your fingernails and hair strands. And a fresh layer of dead keratin, it's white in appearance. If you think about dry skin on your finger or sometimes on the side of your lips, it's almost white, it's see-through, it's opaque. And as it oxidizes, this skin turns more brown and black in appearance. And with skin in the ear, you develop skin ribbons. It's almost like a coiled lump of skin, and you'll see these coils in a moment. So where I'm wriggling now, it's almost like a spring. I can actually feel this. You won't be able to tell by obviously watching the video, but when you're doing the procedure, you can actually sense it. It's what we call kinesthetic feel. And it's almost spongy. You can go backwards and forwards with this. And in a moment, you'll see I'm lifting this up, and you'll have a better view a bit later, I feel. You'll actually see the coils, the curliness of this dead skin. And with this, you just have to persevere. So this dead skin, it can attach itself really strongly to the canal wall. I wanted to avoid drops in this case, just because the patient had already been using a lot of drops, and they said they developed a bit of irritation from the drops. And you can see here these coils. I don't know if you can see at the base of this plug. You can see these little rings, concentric rings. And so the wax is just on the dead skin, should I say. It's on the posterior canal wall. Just trying to loosen it here, but it is very stubborn. So in a moment, I think I'm going to use a combination of an ear hook and some forceps to leverage some of this dead keratin out of the ear. Now, this occlusion is quite deep in the ear. However, the endoscope is literally just past the first bend. So quite often when we train our ClearWax delegates, they get slightly worried about the endoscope because the endoscope is a 5 centimetre rod lens system. Now, the reason why we have it 5 centimetres, we call it working length. If you have too short, when you insert the endoscope into the ear, there's not enough space with the other hand to manipulate an instrument. So because this is 5 centimetres long, it comes away outside of the ear canal and it frees up the entrance of the ear. Just using an ear hook, and I just went to the base of the plug of the keratin and I rotated the hook to get some purchase. It did take some out. I think now I'm going to use some, because there's something for me to grip onto. So with forceps, when you're using forceps, there must be something to grab onto. If there's a flat surface, then forceps are no good because there's nothing for the forceps to pinch onto. Instead, the tip of the forceps, the distal end, is quite pointy and sharp. It's going to push everything further in. So at the moment, I took a big blob out of dead keratin with the forceps, but there wasn't anything to me to grab onto. So I went back in with a suction probe, and I'm just wriggling this dead keratin out of the ear. And quite often when you remove keratin from the ear canal itself becomes a bit blistered because it's dead skin actually, and it's still attached to the canal wall. And you'll see at the end of the procedure, the patient's ear is quite red, slightly blistered, but the patient didn't feel any discomfort, and that's normal with dead keratin, and it will just resolve itself. And now we're on the anterior canal wall, and it's really tightly stuck to the canal. And the further we go in, the more darker this dead skin becomes because it's been there for longer, it's oxidized. So I'm just lifting this off the base of the ear canal. So we're well into the bony portion of the ear canal. So you can think about the ear canal in thirds. The outer third is cartilaginous, it's semi-malleable, semi-sensitive, semi-flexible. So the outer cartilaginous portion, you can apply some pressure without it becoming uncomfortable for the patient. However, the inner 2/3 of the ear canal is very sensitive. It's literally a very thin layer of skin, less than 0.1 millimeters in thickness, tightly adhered to the bone that is called the temporal bone. And if you make contact with the bony part of the ear canal, it's very uncomfortable for the patient. So we just have to, and when we train our ClearWax delegates, always make reference to that game of operation. We want to avoid the bony part of the ear canal. You can see I'm just toying away here. I am loosening it. As I'm pulling it forwards, it's springing back. Remember at the beginning, dead skin in the ear, it tends to coil and it's almost like a ribbon appearance. And because it's a coiled structure, it does bounce backwards and forwards. So you do have to give it a fair tug. So I can just revealed the eardrum at the base. You can just see there's a blue tinge there, so that's the patient's tympanic membrane. So just working this left to right, up and down in little circles. And slowly but surely it's coming away from the eardrum. So if you look at the base where I am now, there's a layer of skin here, but it's not as dark as the skin in the centre of the ear canals. And that's because this lighter shade is a freshish layer of dead skin, so it's not oxidised like the rest of it, and that's why it's lighter. So we can see half the eardrum now anteriorly, so in the right ear, if I didn't mention that at the beginning. And this keratinous plug is actually impacted on the eardrum. You'll see in a moment we actually do have to take this off the eardrum. So we're just on the superior canal wall here, just trying to loosen it, and I think I'm going to go to the posterior canal wall, it's at the back part in a moment. And look at that view, it's just stunning. With an endoscope, it's just panoramic, and you don't get any distortion. So with some devices, when you examine the ear, the suction probe actually becomes distorted in appearance because there's no focus on it. And yeah, it's a bit odd actually, because it's distorted in such a way where it no longer looks like a suction probe. And yeah, I wouldn't want anyone in my ear flaying that around. So just on the posterior canal wall here, some dead skin, just peeling that off. So again, it's a bit lighter in shade compared to the majority, so it's oxidized. It hasn't had the opportunity to oxidize the remaining part of skin. So this is the last piece of dead skin. And to the untrained eye, it just looks like earwax. It's got very similar complexion, appearance, but it's not. It is dead skin. And you do approach dead skin slightly differently to earwax. So the eardrum's in the distance, just a bit of dead keratin in the isthmus region, so about 0.5 centimetre away from the eardrum, the ear canal narrows. Now, I'm not going to... It was starting to clarinet, so clarineting is when dead skin violently flaps against the tip of the endoscope, the suction probe, sorry. So I just left that. It's not going to cause the patient any problems, symptoms completely alleviated, eardrum's nice and healthy. I think I'm just going to mop up slightly at the entrance with some of this dry debris and skin. So I hope you enjoyed that video, guys, and you're all keeping well and safe wherever you are in the world. And stay tuned, I've got some really good videos coming up soon.